focus to the patient care. We have focuses on relief. We focus on relief of symptoms, and that's anything from pain to emotional stress. And I'll go over in more detail, but I tell patients that my expertise is in complex symptom management. Even when there are other doctors involved in the care of these symptoms, we can provide, second, third, fourth layer medication recommendations, or even provide a different view to how to manage some of these symptoms. And really, I think folks understanding that it's appropriate for patients at any age and at any stage of their serious illness, because we provide care along with the curative treatment. Now, I know ALS doesn't have a curative treatment, but if, let's say, a patient has pneumonia and they're getting curative treatments in the hospital, we can be seeing that patient simultaneously and help them. Really, the focus is to help them get through that treatment. We want people to live as long and as well as possible, as long as that's within their goal to get that treatment. And really, we're focused on helping patients and their families or their loved ones and care partners. So as I said, when I explain what palliative care is to patients, I say we are a team that focuses on quality of life. And we do that through my expertise, which is communication skills and symptom management. The communication part is really thinking about goal setting, family support, any emotional suffering, some of the end-of-life tasks, autonomy, figuring out if somebody has capacity, medical capacity. We do dignity therapy and life review, and then even think about financial distress that patients and care partners are experiencing. As you can see, the symptom management is extensive. It's not just pain. And these are just a few examples. One that's not on here is lack of appetite that a lot of our patients or with ALS are experiencing. So we think about that and talk about that as well. So as you can see, it's because we can do a lot of these things, there's a lot of reasons for you to consider palliative care support. And one of the ways I talk to patients and families about communication is I describe it as it really is like formal evening wear. So you want to think about these goals, think about your what you want from your medical care at least once a year or every time there's a big event. And that is something that can happen for people who have ALS at really a lot of times that are unexpected, or even expected. You come in every 3 months and you're seen by the team and you can see the slow decline. And there's a point at which there might be a medical decision to be made, but all along as you're going through that, we're talking about what does this mean? How are the changes? Even if there aren't any changes, what does that mean? And so that's something that's kind of a constant and continuous conversation that doesn't necessarily need to be a certain threshold in order to participate in. So really, there's, this cartoon says there's no easy way I can tell you this, so I'm going to send someone, so I'm sending you to someone who can. And a lot of times that is my role. That is what I do. I help when other providers don't know how to say some of these hard things or aren't comfortable with it, or haven't necessarily there's many reasons that patients or families don't feel comfortable telling their primary team what's going on with them. I've heard everything from not wanting to disappoint their medical team to maybe not having that trust relationship yet, worrying that if they say they're fatigued or concerned about their kind of reassessing what they want, that maybe the medical team will stop offering them medical treatments. So I think there's a lot of reasons to have maybe a quote unquote neutral third party that can be useful. Sometimes a lot of neurologists or primary team members, they see the distress, they don't know how to address it themselves because they either don't have the right words, they don't have the communication skills for such a complex conversation, or they have plenty of other things during that clinic visit to discuss. And they need to get through those things, and they don't want to rush a very important conversation either. So sometimes just because I have the expertise and because I have the time, I can spend the entire half an hour visit just processing through what this disease means for the person, what are the changes, normal feelings. They're not always pathological feelings. And that really can be helpful in terms of thinking about whether the person really, many times it's the person really does want to continue with treatments, if there are any treatments, or they want to get a feeding tube, or but they've heard scary things about it, or they've only seen bad outcomes, and they really just need to understand whether it's the right thing for them or not. And many times I have recommended that they go forward with those life prolonging treatments. I just had a young lady in my clinic this week. She's 41. She has a very, very poor breathing capacity, such that by the numbers, if you looked at the prognosis, it would really be weeks of life left. But she was really thriving. She had a beautiful, supportive family. She has 3 very young children under the age of 5. And it was part of her goals and her wishes to, and she had just been diagnosed in December, and was admitted to the hospital for a long period of time. And I was meeting her for the first time because she was diagnosed during that hospitalization. It was really, really unfortunate. And we had a conversation about with with her and her husband about the interventions that she would really need to think about carefully very quickly, unfortunately, things like a feeding tube and a tracheostomy to help her breathe. And she was terrified, but she really wanted to live. And she was young, so we talked about things like CPR if her heart stopped naturally, and actually recommended, because she's young, even though she has terrible breathing, that we do those things for her. And it was very much consistent with her goals. So not all conversations with a palliative care specialist will lead to stopping everything or changing to do not resuscitate. Many times, if they're consistent with the goals, we will recommend exactly to do aggressive interventions. So it's something that the conversation really led to good outcomes, and should be and will be really normalized in her daily, in her regular visits. Every time she comes, we're probably going to talk about this, and that's also something that can do in a way that doesn't feel so scary or abrupt, that it becomes part of the regular conversation. So all those things that I described as you've heard, a multidisciplinary approach, right? We take care of not just the medical conversations or symptoms, but we take care of emotional, psychosocial, spiritual, financial. And so we have a multidisciplinary team. So we call it palliative medicine because that differentiates between we call it palliative care and not medicine, because medicine really only refers to the discipline of medical care, where it's the physicians or the advanced practice practitioners. And really the care part of it is caring as a whole person, as a whole being. So this is my team from the inpatient team at Bayview. We have a nurse, we have a nurse practitioner, a social worker, we have a few physicians, we have a chaplain, we have a coordinator, we have a pharmacist, and we're very lucky to have such a diverse team. Most places, as most of you are thinking right now, is I can't even find a palliative doctor in my area. And that is certainly something that I think has been a very great challenge, and is something that we're working on not only as a field to increase the number of palliative care specialists, but more importantly, to increase the number of palliative care skills of the primary neurologist in your primary team. Because as I described, palliative care is about quality of life and helping people from symptoms to communication. And these are not skills necessarily that only a palliative specialist like myself will do. These are skills that anybody who's taking care of any person, even patients and care partners, do palliative care for other patients and care partners because they're improving their quality of life. The people who clean the rooms in the hospital or the clinic, they're providing palliative care. So when we talk about palliative care, we really truly mean quality of life, and it doesn't necessarily mean a separated out kind of care. So I'll tell you a little bit about the other aspects that make palliative care valuable, right? We talk about improving quality of life, decreasing symptom burden. In studies, they've shown that palliative care can reduce symptom burden by about 66%, at least 66%. And those symptoms can be improved for lasting months, even after one consultation. And there's very high satisfaction and positive patient experiences associated with seeing a palliative care specialist. And often they're going to recommend it to other people as well. And as a system, it helps. This is not the primary goal, but it does help, especially if you're trying to expand for the healthcare providers who are trying to advocate for more palliative services in their own institutions. This can help to support your argument that there's a value in reducing costs and spending, and in all the settings, healthcare settings. 48% of readmissions for the inpatient side, 28% cost per day decline. In the outpatient setting, 50% of admissions to the hospital, and decreasing ED visits by 35%. If they're in a skilled nursing facility, then it decreases hospital and ER transfers by 43%, they've found. And if patients are at home, it can decrease costs by about a third for their total healthcare costs. So it helps in all settings, and is something that this is a few years old now from the data, but really can help to support the value to the leadership who are thinking about how are you going to pay for yourselves. To be honest, usually palliative care doesn't make money for a system. We save money, like you're seeing, or we prevent spending. So it's kind of invisible costs, and that's usually our tricky situation where we're trying to prove our value without being able to say, we're making a good amount of money for the hospital. We're almost always trying to at least just prove that we're gonna keep steady. And the hard part is that, well, the wonderful thing is over the years, the penetration rate, the number of palliative care teams in hospitals has significantly increased. But the home and outpatient services are lagging behind. And that is kind of the next forefront for the field of how to do that. And folks like myself, the models of care have varied from folks like myself who are embedded in the clinic, which means I go every 2 weeks or every other week to the clinic in our clinic, which is when our clinic happens as the ALS multidisciplinary clinic. And I start at 9 or 8, whenever the team starts, and I stay through the end of the day. And I don't have any patients particularly slated to see me. I just walk into every clinic visit and say, this is who I am. Do you want to talk today? And most of the time patients will want to talk about something. I found that in my studies from UCLA that we did a retrospective study, and we looked at patients who I had seen on just the first visit. And of those patients, I talked with them about at least one of goals of care conversation or topic for 96% of those patients, which meant without even knowing me or having a built relationship or foundation, people were wanting to talk and they were willing to talk, and they were thinking about these things before they came in. I often will find, I once had a woman in my clinic who I had seen her before, and I went by to see her. She was quite on top of her things. Her disease wasn't changing pretty significantly. She's one who, if like in the traditional model where the physician would put in a referral and then they would come to my clinic separately, that's a more traditional model where you see, any other physician who's a specialist, you get a referral, you go to their clinic, they probably wouldn't have made that cutoff. There wouldn't be enough warning signs to say, oh, this person's really struggling, they need to see this person. I visited her in the clinic. I peeked in. She said, I think I'm good. I don't really need to see you today. And I said, okay. Yeah, actually, can I ask you a really quick question? I want to know about whether I'm thinking about moving out of my apartment, or I kind of just want to know when I should think about getting a care provider for myself, because she was alone. And in that conversation, we literally ended up talking about everything from her advance directive to hospice to when to fill out paperwork. And it was just a very full conversation. And it didn't change anything of her care. She just needed to know about it. In fact, she even in that conversation asked me about medical aid in dying, which is a pretty sensitive topic. And I don't think she thought we were going to go there. But, it was very necessary for her, and she felt relieved after. So you never know what's going to come out of them. Um, so there's a myth out there that palliative care shortens people's lifespan. So I'm going to give you some data so you know that this was a seminal study that showed that by Tamel and colleagues, and it was published in the NEJM, which is a pretty big journal. And what they showed was this was a study actually of patients who had non-small cell lung cancer. And it was a randomized controlled trial, which is a very high quality data study. And they had metastases, so they were pretty advanced cancers. And they showed that the people with the red line were those who got palliative care by a specialist. And then the other was standard of care, which was still some palliative care, just delivered by the oncology team. And as some of you may know, an oncology team is pretty comprehensive. They usually have good support, social support. They're very on top of their patient care. They will follow them quite regularly. So they were getting good quality care. And when they adjusted for age and sex and oncology, like how sick they were, what oncology group performance status, which is what's needed to kind of assess how well someone's doing. In ALS, it's the similar score as the ALS FRS functional rating scale. And they showed that when patients got early palliative care, which means early meaning like as soon as they were diagnosed, basically, they found that patients over that time lived longer, a few months longer, which for those patients was really meaningful. And they actually showed that it helped with their emotional distress as well. So that really set off the whole field. This helped to show and make the argument that palliative care was not meant to be just for end of life. It really is meant to be along the way. So this shifted the paradigm of how we practice palliative care in the system. So the old method was what I was describing. You get diagnosed. If you can see my pointer here. So you get diagnosed, and then you have all these opportunities. They're getting their disease. This is where you hear patients say, healthcare providers sometimes say they're not palliative yet. They're not ready for palliative yet, but they're getting palliative care just from other people, not from a specialist, or they're not talking about goals of care. They're having lots of symptoms that are coming from their disease-directed treatments or from the disease itself. And then they start to lose response from those disease-directed treatments. Those treatments are no longer helping in a meaningful way. And of course, I know for ALS, there's no cure. But if you took, this model was often in the framework of cancer, because it's one of the earliest, like I showed Tamel's study was for patients with cancer, and it's been one of the earliest kind of pairings of diseases. But for ALS, this is the same, right? You get patients who are not going to get cured, we know that, but they're getting disease modifying treatments and they're having complications, or they need to think about feeding tubes, and they're focused here on their disease only and not necessarily thinking about how to make their life better as well. Then only when they start to say, oh, these treatments aren't really working very well, I'm declining despite them, I'm ending up in the hospital a lot, then they consult palliative care. And then soon after, because those things are starting to happen because they're closer to the end of life. So by definition, they're closer to hospice care. And so then you only have a very short amount of time for palliative care to be involved, to have those conversations. And they often, at that point, do lead to conversations about hospice care because the options are limited, because the patients aren't doing very well and they really are done with things. And so this is a lot of why the model of care of palliative and hospice has been confusing and they've been conflated. And because in this country, hospice care was older than palliative care as a specialty. Hospice care, and I'll talk about in a minute, came in the 1980s as a Medicare benefit. So the term has been around a lot longer. There's been less palliative care specialists, and in other countries, palliative care is hospice care. Because of the models of care. So there's no hospice care because hospice is a US Medicare benefit. In other countries, palliative care is just a continuation of the care that's provided. So as people understood better and better that palliative care can help in certain ways, the model of care changed, and we started to argue that there is benefit to seeing a palliative care specialist as early as diagnosis for some people, especially, for example, like this woman that I met, that young lady that I was just telling you about earlier. And then there's a lot of opportunity then for bereavement care as well for patients who have hospice care. So what I tell the learners and tell other people is that hospice care is palliative care. All hospice care is palliative care, but not all palliative care is hospice care. So now that makes a lot more sense. So let me tell you what hospice care is so you can understand that a little bit better. Hospice was started actually as an entity in England by this woman who was later knighted to be a dame, and her name is Cicely Saunders. She actually started as a social worker, and then became a nurse, and then became a physician. And so she walked the path of all of these interdisciplinary roles. And she happened to marry a gentleman who was very wealthy. And when he died, he gave her a lot of money, and she used it to start the first hospice. And she did it in such a way that she didn't just create a space for the care of people at the end of life, but she did it in such a way to create the interdisciplinary team, because she had worn all these hats and she knew the value and need to have more than one aspect to the focus of care. And so this is the first hospice, St. Christopher's. It was opened in 1961. And there's actually, for those who are interested, a Cicely Saunders Institute that does a lot of cutting edge research out of the UK. And so this is the hospice model of care. It is where you have, as you can see, it's quite similar to the inpatient palliative care teams, or palliative care teams generally. You have a physician, you have a case manager, and a nurse. You have a certified nursing assistant, you have a social worker, you have a chaplain, you have a bereavement counselor, and actually on here are also volunteer services. And sometimes you can have two physicians. You can actually have the physician who is the physician of the hospice, and you can have I guess you always have two physicians. You have the physician from the hospice, and you can have your primary care doc, or you can have your neurologist, or you can have your oncologist, or you can have, for some people, their palliative care doc. Depends on who can serve in that role, or who the patients and family really want to continue on, because we want to, really want to continue that relationship and help guide that care. Certain things kind of have to be in place for that. So for example, you want to make sure that the physician who's going to be your hospice physician can be on, them or their team can be on call 24 hours a day, 7 days a week, because they'll be the ones getting the phone calls from the nurses who come to the house to see the patient. Hospice is run by nurses. And the hospice nurses are incredible. They are so knowledgeable. They have such, experience to know how to handle things in the field, because most hospice is actually provided at home. And so the nurses come once a week to see the patients and the families, and they'll then, when I was a hospice physician on call, I would get the calls from the nurses, and it can be any time of day, 3 a.m., 10 at night, nights and weekends. And that is the purpose. You want to have a physician and a nurse on call 24 hours a day, 7 days a week, so that any symptoms can be managed immediately. And what happens is the nurse calls the physician figures out what's going on with them. and they call in a medicine right then and there. So there's nobody going to the hospital unless the patient or family wants that. There are a few cases of that, which a patient who falls and breaks a hip, it can actually be in line with hospice care to go to the hospital, get that surgery done, to maintain their mobility, especially if they've been very mobile and very functional before that. Going to the hospital, getting the surgery done, and then actually re-enrolling in hospice again and going back home. That's very, very consistent with hospice care. But for the most part, if somebody is developed a new pneumonia and they're really short of breath, you want to be able to address those symptoms right away. And so that's what the physician does. So you want a physician who's going to know that person and their family, who knows their goals, who's seen them at least recently, who can help guide that care. If you don't have that, or the patient doesn't really feel particularly close to their physician, then the hospice will provide a second physician who is the medical director or one of their physicians to ensure that there's always somebody on call. And then the hospice must provide certain medical equipment like a bed, a bedside commode, a desk, walkers. If they have an ostomy, or if they have a drain, they'll provide the equipment for those bags to change those bags, and any kind of other medical supplies that's related to the diagnosis for which they're going into the hospice. So it would be for ALS, it would be ALS. And any medications related to the hospice diagnosis. Now that's tricky, to be quite honest, because many medications are pretty expensive. And so hospices make decisions out of cost, thinking about the finances. And it's not fair, but it is the way it is. And so if like, for example, for patients who are on Radicava or Relivrio, or Riluzole, they'll stop those medicines. Now there's one might say, well, that's not fair, I want to continue. So if you have a second insurance that will pay for it, they will not stop you from getting those medications through those secondary insurances. But they will not measure, like if you're getting labs tested, for example, like liver testing, they won't do those labs. So I think it's important to understand what's going to stop. And those medicines are, at a certain point, they're not helping any longer, which is often why we're planning on hospice. So if they're not helping any longer, then there really isn't a benefit to taking them. So we stop them for those reasons as well. The tricky part is for patients who have ALS, there's many expensive pieces of equipment that you would benefit from, that you do benefit from, and that are good, are actually quite in line with the goals of improving quality of life. Things like the motorized wheelchairs or the eye gaze machines, and those things. So what is unusual about hospice for people with ALS is we actually will delay the onset of hospice or the enrollment of hospice till people get those equipments that they want, because often those equipments are coming from associations like the ALS Association, who are kind enough to lend those to patients and families, and they're too expensive even for full insurances to provide. So we want to make sure that we're taking advantage of those resources, and we'll often wait until you get those resources from partners. And then when they're no longer helpful, we return them, of course, but they've been kind enough to allow us to use them for patients and care partners through the end of their lives. So we should get them and use them. So those are some things to think about in relation to hospice and ALS specifically. So hospice is specifically for people who we think would live less than 6 months or less than 6 months, based on how the disease is progressing, what we can see right now. Now, people live longer than 6 months. And so at that 6-month time, the timer starts again. You ask the same question. Based on how the disease has progressed, do we think that this person will die within the next 6 months? And if the answer is yes, and you can prove it based on these Medicare criteria, you're good to go. I've had patients live in hospice, under hospice care for 2 years. And they have some patients that they say, she's like, I hate this term, but you'll hear it. They graduate from hospice. is a terrible term. It really is that they have their disease is progressing not as we expected, because these things happen, and that's a wonderful thing. It's a pro and a con. They're living longer, they're living well, they're not declining. So then they say, okay, for hospice services, we're going to stop them for now. And then if you see changes again, of course, you can re-enroll. The hard part about that is making sure that they don't fall through the cracks, they get back to their medical care as they need to. The other time to think about hospice is when the patient or the family is ready to change their focus of care to being comfort as the priority over everything else. Usually for people who have ALS, what that means is, because you've been focusing on quality of life, that is what we can offer for people with ALS. But what that means is when we say we no longer want to go to the hospital, we don't want to get aggressive treatments any longer. If I further decline, I only want medicines to keep me comfortable. That's appropriate for hospice care. We talk about things like their code status, so that's the CPR. We talk about things like the aspects of non-invasive ventilation, the BiPAP, the CPAP, and then we talk about things like blood pressure medications, antibiotics, IV fluids, artificial nutrition. But those are not things that if somebody tells me I don't want BiPAP, I don't say like, okay, well, you're ready for hospice. It's really the fundamental philosophy of care that I no longer want to, for ALS, I no longer want to go to the hospital should I get an infection. I no longer want to continue my artificial nutrition. And with that, my priority of comfort is over everything else. So that is the philosophy of care of change. And that's what needs to be kind of at the forefront of that conversation. When we think about how do you know, there's this surprise question, which can help physicians figure out, or healthcare practitioners who are having to decide this specifically. Would you be surprised if your patient died in the next 6 months or less? And the factors to consider for that are their primary diagnosis, if they have any other comorbidities. And I really think about it in the broad picture of function, nutrition, and cognition. Have those declined, and how quickly have those declined? And this all goes into the prognostication conversation, which are understanding how these diseases generally decline. Now, these are the next few slides are really relevant to other diseases, but this is the picture for ALS generally, big picture. People tend to be real slow and steady in their decline. And then at a certain point, they really tip over and they have a major shift in their symptoms and a major shift in how much support they're needing. That's also what cancer looks like. So we're kind of watching to see, and we're trying to catch people really. This is why goals of care matter here, because you want to get to know people, you want to understand their priorities. And then here is where you're really trying to catch them ahead of time to make sure that before this happens, where they can no longer talk to me, where their families are having a lot of distress, that we're not making decisions in a big urgent matter. We're making thoughtful decisions. But how you feel as a patient, how you feel as a provider, how you feel as a care partner, that will change as you go along. So you want to have the opportunity to reassess, because if you're thinking of something that needs to change here and no one's asking you until here, that's not good. That means that potentially you may have wanted to change things here. Maybe you didn't, but at least you should have the opportunity to have that conversation. Just to give you a comparison, this is where people like, this is your common heart, lung failure, organ failure, kidney failure. This is what it looks like where, you have an acute event, then they get better. They're never as good as they were before in terms of their function, nutrition, and cognition. Keep readmitting to the hospital, then maybe they have a period of stability and slowly decline. And then this is like dementia. This is Alzheimer's disease. They're quite frail and they decline slowly, and it's really hard to know what to do. This can also look like patients who have ALS with dementia. And we know that physicians, I tell patients all the time, and people I tell my learners, we're humans. The medical team are humans thinking about humans. We're not God. So we're going to make mistakes, and we know we make mistakes. And so, but what helps to minimize the impact, the negative impact on patients and families when we do make mistakes about prognostication is really, there are studies that have shown that the families who are asked after the loved one has died about the conversations that were around hard decisions, regardless of how that situation turned out. If their loved one died, they still have no regrets as long as the conversations were done with kindness and love and compassion and transparency. Really, it leaves the legacy with them that their loved one was well cared for. So we talk about hospice is not a place to die. We focus on making it the most of each day, and it's focusing on quality of life and comfort over everything. Hope is a huge component of what we try to maintain from hospice and palliative. We ask, what are you hoping for? It's not a loss of hope. It's just, we're going to change what we're hoping for. We're using different tools. We've always hoped to give you good quality of life. We've always hoped to help you live longer. We've hoped to keep you at home. We've hoped to keep you with your family. And palliative care and the aggressive measures, that's what they're trying to do. And when they're not doing that anymore, I tell patients that we're just changing. We're going to still fight, if you like that metaphor. We're still on the battlefield fighting. We're just using a different sword versus an arrow, and you're going to have different tools for the different types of battles. So we're always hoping, we're always going to be, planning on that. And here are a couple of papers that really talk about the healing power of hope, how we never lose that. It's just switching what we're hoping for. Hospice can be provided, as I said, at home. There's different levels. You'll hear home hospice and inpatient care. It really is dependent on how many symptoms that person is having. But people always ask, do I have to go to hospice? Like, do I have to go somewhere? And we say almost always that hospice is done at home. The problem is, for most people, who's going to care for them 24 hours a day is the biggest limiting factor. As I showed you in the other team model, there's no 24-hour caregiving. It falls on the patient and family. It is a huge burden. It is a huge gap in our medical care. It is something that the palliative and hospice agencies are trying to advocate for, to try to support families more, but hasn't happened yet. And that's not going to vary hospice to hospice. That's a Medicare thing. Very, very briefly, you hear the words comfort care. Comfort care is a subset of hospice and palliative. When hospice is not available or a patient cannot get, for example, from the hospital to home hospice, then we provide comfort care. Or in hospice, comfort care is really the last couple of, somewhere between the last few hours to last few days of life, when someone is no longer able to take other medications. This is important because there are people who have, for example, low thyroid disease, right? And they're taking a thyroid medicine. That's going to help them live longer. Just because they enroll in hospice doesn't mean we stop that, because it's going to help them not just live longer, but help with their quality of life too. You don't want them getting thyroid symptoms, for example. So what this really goes to show people is that just because you're enrolling in hospice doesn't mean they're going to stop all the medicines and just give you morphine and have you die. The idea is you use the comfort medicines for comfort when the other medicines are no longer helping. So that's the whole idea, that comfort care is truly focused on only comfort medicines when the person can no longer take the other medicines that were giving them comfort at that time. So I hope that this helps you really have an understanding that palliative and hospice both have interdisciplinary teams, that we're really experts in communication and physical symptoms, and that we really are different than hospice, which is also different from comfort care. There are a few organizations here that I thought might be helpful in terms of referencing. The first is the International Neuropalliative Care Society. It is totally free. There are a ton of resources there. It is really grassroots. It's only been around for the last couple of years, but we have conferences. It's open. What I really like about it is that it's truly multidisciplinary, not just healthcare multidisciplinary, but we have a ton of patients and care partners and advocates and non-healthcare provider related stuff, which I think is really different from the other organizations, things like the American Academy of Neurology. It's more similar to the ALS Association, where you have, patients and advocates who are ambassadors and are really integrated into research and programs and support. And that's what we're trying to do. It's just not specific to ALS. It's trying to be specific, general to all neuropalliative care. And then the Palliative Care Fast Facts has some really good basic like really evidence-based materials that are really good for those who are teachers, actually also for learners that you want it, and they're free. They can hand them out to them. And then the Center to Advance Palliative Care is where I got a lot of that info for in about, you know, the value-based care. There's free slides on there that you can use to advocate. And then the National Hospice and Palliative Care Organization will give you a sense of if you're looking for hospice reference resources, and it does have a map on there of the organizations, so you could look nearby you wherever you are. It's not complete, I will say. So some of them will call themselves hospice and palliative, but only have hospice. We're working on that. So hopefully these help you. And I'm going to stop there and say thank you so much for having me. And I'm really looking forward to questions and conversation.
Thank you so much, Dr. Mehta. And I tell you, we're going to jump right into the questions so we don't waste any time.
Thank you.
So let's go at the top of the questions and work. Oh, it is being recorded. That I can answer that one. Oh, and I'm not going to tell you someone's saying that tech's better than UVA. We're not going to go on that one either. But this is a tough group we've got here. So question is the palliative care team part of the ALS clinic? How are they integrated? This is a two-part. So let me, I guess, read the second part. We are in need of a palliative care team and only have one nurse. We were just dismissed from home care team of PT, OT, and speech, and now have one palliative care nurse, no plan, and don't know anything.
Oh my gosh. Oh gosh. I'm so sorry. That is so difficult. And I think you're actually, from what I've heard from others, you're not alone in this challenge. I will say that, so every place is different, and it's going to really vary based on what are the resources available. Like, for example, in my own clinic, I'm the only palliative person. I am in my ALS clinic. I'm the only part of my team, just because, you know, and I find it challenging in that, like, for example, I can't come home with people, or I can't provide home care services because I only have myself. So I say that to say, you're not alone. This is a common conversation that we're having. And the so if you're at home and you have a home care services, sometimes there are organizations that do, I would think about either palliative care through a home care service that does, maybe isn't called palliative care, but they're doing elder care programs. So for example, in this area, Gilchrist is a hospice agency, but they have paired with it elder home care program. So when I need a home care palliative program, I actually ask them, I refer the patients to the home care program, because they've got at least they have the ability to see people in their home regularly, and they have a little bit more of a team. So I would ask your neurologists or your team to ask them about home care providers. And I would ask them if there are any I would also, if you're looking specifically for a palliative care physician, you can ask them for who the inpatient palliative care teams are. And many times they will know who the resources are. You can at least reach out to the palliative care team and see if they can provide you with who are the home palliative programs in your area. And then you can take it back to your neurologist and ask them for a referral if that's needed. It's real hodgepodge right now, but that is kind of the workaround that I have found. And I hope that's helpful.
I know that was helpful to me in trying to find the palliative care. Thank you. Yeah. So where do you recommend clinic staff go for palliative care training to supplement their clinical skills? I love that question.
Yeah, I love that question. Actually, so the one that I provided, the Center to Advance Palliative Care, they have a lot of, they have some training programs. And there are some training programs that are online. So if you look up palliative care certificates, certifications, there are certifications that are available. And actually the other one I provided, the NHPCO, the National Hospice and Palliative Care Organization, they also have training programs. Now, the American Academy for Hospice and Palliative Medicine, that's AAHPM, they have certification programs as well. However, those you, I believe, have to be a member of that organization. If you choose to not do a certification, but you just want to be linked in, maybe it would be worth getting a membership to the AAHPM and get connected to other, they have a lot of, like, for example, communities and working groups and things like that, that could help you along the way. And the International Neuropalliative Care Society and some of our other groups, we are all forming these little conversations in communities where people just ask us questions about their clinical care, and we can collectively give answers. For example, sometimes they'll say, I'm having a patient with really bad symptoms of secretions. What do you guys use? And then we can share notes that way too. So if you can't either afford the time or the money because your institution can't support that yet, to get a certification, these are other kind of freebie ways to kind of get some advice or knowledge, or at least just to be connected. And then you can keep the conversation going with folks like myself or other people in the field who can give you more resources.
Thank you.
Mm-hmm.
Can you discuss a little more about respite care? I have discussed this with the family to provide a week or two of total care to allow family vacations or stress relief, etc.
Yes, actually, that's a perfect example. I mean, that's a perfect description. So respite care is built into medical, it's part of a Medicare benefit with this hospice benefit. It provides coverage of care for 5 days, specifically for families to do exactly that, caregivers to take exactly the break that you mentioned. It's 5 days every 90 days of enrollment. It's either 60 or 90, but you have to be enrolled in hospice for at least 60 days. And so I believe it's 90 days, but it's at least 60 days of enrollment before you qualify for the 5 days of respite care. What that looks like is they will take the patient to their facility, that inpatient hospice facility, whether it's at a nursing facility or their own freestanding facility. They will transport the patient there. They'll stay there under home level care and get medicines and everything, and then they transport them back. So that's what that looks like, and it's part of every hospice benefit care, no matter what.
Okay.
Yeah.
So someone said that the audio was garbly on their side. I hope not. I hope not. Normally, if it would, one of my coworkers would have been texting me, so I didn't get that text. Any other questions or follow-up that anybody has? We will be glad to answer them. Give it a second, and I think so far, let me click off and go back in so I'm not missing anything. Oh, it's good. It came back. The audio came back.
Good.
Good. Very good. Very good.
I am
not
happy,
always so trusting with the.
I am happy to, if I'm not sure how you'd like that, but I am very happy to share my email. If anybody would like to get in touch with me, for the nurses, for example, who asked that question about getting more advice, I have a fabulous nurse on our team, nurse practitioner, who is quite involved in nursing education. I just also thought about the ELNEC, the end of life nursing education curriculum, ELNEC, that I personally am not involved in, but there is that curriculum if you look it up online. But I would be happy to either help with any connections to any of the organizations I'm part of, or get people, answer questions, or to connect you with anything I can. So I'm happy to give you my email or to tell you now, whatever is better.
Got one more question here. At what point of time will clinic bring in palliative care?
Yeah, it depends on the clinic and it depends on the disease. So if we're talking about specifically ALS, what usually happens if it's a referral based is either somebody, there's no trick, they have not published any specific, if you meet this and this and this guideline, then you get referred. What it usually is if a patient or a family is having a lot of symptoms that are uncontrolled, or if you really need to have a conversation about what they want with their medical care, and the medical team has tried and maybe the conversation hasn't gone so well, or they need a little help, or there's a lot of complicated family dynamics, like the patient wants something, the care partner doesn't agree, or the patient care partner on the same page, but the family, extended families, like not in agreement, then those are reasons to refer. Sometimes I just say the easiest thing is, honestly, if you think about it, you probably should refer, because that means something in your gut is telling you things aren't settling right, or you need a little help. Because we can always see them and say, you're doing a great job, everything's good, keep doing what you're doing. And that's fine too. So there's no set triggers right now, but usually those are the most common reasons.
Okay. Oh, here we go. When do you suggest filling out palliative care paperwork? Obviously not at the last moment, right? I almost don't want to think about it right now.
Yeah. Okay, so the answer you don't want to hear is you should do it now. And I will say this. So the paperwork is really the fundamental purpose of the paperwork is to ensure that your wishes are known, whether you can speak about them or not. So I think about it as the hardest part is not filling out the paperwork, it's the conversation that comes with it. So as long as you have told, I would say the most important thing out of everything is designating your healthcare agent, the person who's going to speak for you if you couldn't speak. In many states, it's a default to, there are defaults and there are hierarchies. So if you don't want, for example, your spouse, in Maryland, it goes to your spouse if you're married legally. Let's say you've been separated from your spouse for decades, but you never formally divorced, it would go to that person. So I would say the most important thing is to designate the person that you want to speak on your behalf, and then sit down and tell them what you want. And it should be an ongoing conversation, because what you want now is not going to be what you want in 3 months. And that's normal. That should be the way it is. So the paperwork is scary. It is only meant to protect you and to give you control at a time that you may not have so much control. But if you don't want to fill that out, that's fine. You just need to make sure that somebody knows what you want, so that things don't happen to you that you don't want. And that includes things happening to you that you do want, right? If you want resuscitation, if it's really important for you to know that you've done everything possible, even if it's painful, then that's important, and you need to tell somebody. I usually start to try to have at least introductory conversations about this as soon as someone is meeting me, and really just gently, so we have time, so you can ease into this, because a diagnosis is already terrifying enough. So, and I've had many people change their mind. They'll say in the beginning, I want everything, and then later they'll say, I don't want anything, and vice versa. And then as we go along, we still talk about it. So that's hopefully to give you and your loved ones it's a really big gift to give your loved ones the knowledge of what exactly to say when the doctors say, so what would your mom want us to do for her? And what would she say if she were here? And instead of having to guess, you've just told them. And that's really helpful.
Thank you. This is going to be our last question. And then is there an assessment done by someone?
A palliative assessment, I'm assuming, is my guess.
I'm assuming, yeah.
Yeah. So there are different assessments. Actually, it is what we're looking at right now. I'm doing a study right now through the Northeast ALS Consortium, through NEALS, to understand first of all, what quality of life tools there are that are being used and being measured, kind of being regularly incorporated. There are surveys and things like that teams use to ask about how quality of life is going. There's a symptom assessment that people can use. And we're trying to understand, how are people using them? What are they doing with them? Are they even useful? And certainly, you get asked every time you come to clinic, the ALS FRS scoring, which is used to guide care. There is no standardized quality of life. There are validated quality of life tools that are, but there's no standardized care tool that like the ALS tool, like the ALS FRS. There's no standardized one of those. But there are things like I am ALS, that website. ALS Association has a lot of resources on their website, and people use a mix of those. That's what we're finding. So hopefully in the next few years, I'll have an answer for you about that to say, yes, we are using this or we're not using this. But right now it's a little bit of a mix. And so that means you can't really be wrong. It means you can stick to, pick something and stick to it. That's what I would use.
Well, Dr. Mehta, I just want to thank you so very much. This was really informative. And as I said earlier, a well-needed topic. So I want to thank you for taking your time during the day. And I want to thank everybody who showed up and listened. It was recorded, so we'll have it posted fairly soon. And thank you so much. I do appreciate it. And you have a very good day.
Thank you. You too. My pleasure. And have a good one. Thank you again.
All right, y'all. Bye, everybody. Thank you.